Yeah. Thank you so much. And I have to tell you what a great honor it is to be a part of this program year after year. And more importantly, for Dr. Mohan to give this topic, which is on prevention of diabetes, which I think we really need to focus. And every single one of you here, whether you're a GP or an internist or a diabetologist, endocrinologist. Okay, I'll use this. Okay. So the topic today is on preconception care. That's one strategy. And also proper GDM care is another strategy, both for prevention of diabetes. And first, I'll just take a couple of minutes to explain the rationale for this conversation. And you all know that diabetes is on the rise, and we were thinking that we are going to hit about 600 odd million people by 2030. And then the bombshell news came that we have already crossed 800 million. That came out on November 14th, 2024. This was published in the Lancet. So much so that if you go to the WHO's website, it just now shows the new number, 800 plus. And in India, we have apparently 200 plus million people with diabetes, and half of them are women. And why is that important? And any of you who have listened to me before have heard me talk about how so important it is to focus on women, because diabetes in women is different and more difficult and disabling and deadly and all of those things. And again, very importantly, diabetes in women or pre-diabetes or metabolic syndrome or any of these things that we are talking about actually sets them up for a high risk for future diabetes and gestational diabetes. And therefore, they're all risk factors for what we can work on in the preconception phase. Also, because when you look at women with diabetes, the mortality is higher. You take any part of the world except North America, even though men and women, there are equal number of people with diabetes, more women die every year of diabetes. So it's so important to focus on women. And that's because if you see here, every complication, be it coronary heart disease, stroke, dementia, vascular dementia, chronic kidney disease, end-stage kidney disease, cancer, have all shown to be higher in one form or fashion, and therefore the higher risk why women, plus gender issues as well. So the question then comes, why do we have to focus on women of reproductive age? And if I give you some numbers, there are more than 300 million women of reproductive age in India alone. That's the population of the United States. It's a low-hanging fruit, and it's multi-generational impact. And GDM, which Dr. Mohan and Harita have so nicely talked about, that they are at great risk for gestational diabetes and for non-communicable diseases. So we need to focus on this particular group. And there is a paradigm shift. We always talk about a healthy mom has a healthy baby. Suddenly one morning you can't wake up and be a healthy mom. You have to be a healthy woman, a healthy girl first. You become a healthy woman, then you become a healthy mother, and then you have a healthy baby. So that is the important thing, that we focus on this person, the person who's trying to get pregnant. So I think this is the rationale. And I'm going to show you two more very important data, one coming from Dr. Mohan's group, the CARS data, which shows clearly that women, young women in Chennai, if you see there, nearly 30% plus have pre-diabetes. Huge number. That's why I said low-hanging fruit. You can catch these people and work on them and prevent diabetes. And secondly, in this study, again from India, chronic non-communicable disease burden among reproductive age women in India, if you look at this survey, not only there is like a single morbidity, but multi-morbidity is so high in women of reproductive age, which is why we need to focus on this group. In another study from the UK, this is a UK audit, which will show you even women with pre-existing diabetes. We're not talking just about any girl who's getting pregnant. People with known diabetes, look at them, not well prepared, huge percentage of people. So whether they have pre-existing condition, no pre-existing condition, they don't come for, pregnancy planning. They may want to have a baby. So when we say 50% of pregnancies are unplanned, they're talking about people wanting a baby or not. But even those who want to have a baby, most of them no planning. So in that respect, 90% plus are actually unplanned pregnancies. But I just want to say, whatever I'm going to say in the next 15 minutes is all summed up in this one slide. This is an editorial from the Lancet, where they said, campaigning for preconception health. And here they said, a campaign for preconception health, therefore, needs to be a clever, three-pronged approach, taking the different preconception phases and definitions into account. And then they also said there should be no obesity strategy, no undernutrition strategy, no non-communicable disease strategy, no adolescent health strategy without including preconception health. So they've done my talk for me. So this is what we all need to now shift gears and focus on, this 300 million plus people. And so what are these three phases? First, the biological perspective. The woman who is planning a pregnancy for a few days to a few weeks before that, for her to take folic acid, for her to do this and that, not take anything that is possibly unhealthy. The individual perspective is intention to conceive, time frame of weeks to months before pregnancy. And of course, then a public health perspective. How do we get our adolescents healthy? How do we get our young women healthy? So that's a larger perspective. So all these three phases have to be taken into account. So what is preconception care? What is the aim of that? It's simply the provision of biomedical, behavioral, and social health intervention to women and couples before conception occurs. So we want to improve, obviously, the health status and reducing behaviors and individual and environmental factors that could contribute to poor maternal and child health outcomes. So very, very simple kind of an explanation. Now, so why do we think we need it? I already told you, most pregnancies are unplanned. And women entering pregnancies now are older, heavier, having pre-diabetes, other complications, thyroid, PCOS, vitamin D, domestic violence, you name it, it's there, and mental stress. And then, of course, we all know the first 8 weeks are critical for organogenesis, and the window closes. So when women come to us 8 or 9 weeks after they have missed a menstrual cycle, it's already what they say, the horse is out of the barn. It may be a tad bit too late to do anything, and all studies have actually said that. And intervention after the start of the pregnancy have not yielded the required results. And then we also know about the Barker hypothesis, which I'll show you, where the developmental origin of health and disease. So because this baby who is growing, if the baby is small, greater risk for diabetes, future. If the baby is big, future risk for diabetes. If the baby is programmed with gestational diabetes, future risk for diabetes. So very important that we optimize the baby weight also and baby's health also. So the Barker thing. And finally, as an endocrinologist, I want to tell you, pregnancy as a window to future chronic disease, be it diabetes, cardiovascular disease, cancer, mental health, osteoporosis. If only we knew that if we took the women who were high-risk pregnancy, first of all made sure that they didn't have a high-risk pregnancy, but if they did have, we did not let them out of our sight, we followed them, maybe we wouldn't have the kind of burden of NCDs that we are having. Just to show you this, that all of these are actually risk factors for NCDs in women, which are all problems during a pregnancy. And I mentioned already this defining the preconception period, and very nicely you can see, anytime we want to make these changes, like you want somebody to stop smoking, it may take only a few days, weeks, months. But if you want to fix things like obesity, it may take months to years before we can bring them to where we want them. And then I also want to mention another thing. We think of preconception health, and one of the important things that we miss is the woman who is having a second baby or a third baby. So the postpartum period is actually preconception for the next pregnancy. So even if we miss the boat in the first one, we can still do the second one. And there's a very important point I want to make. If after the GDM in the first pregnancy, her risk is tenfold for type 2 diabetes, if it happened again in the second pregnancy, it's 15-fold. So if you can prevent GDM in the second pregnancy, you've actually cut down the risk for GDM as well. So I'll end the preconception talk and go to GDM, but before that, screening and management of pre-diabetes metabolic syndrome, women of reproductive age through preconception care, screening and management of obesity in women of reproductive age, and third, addressing PCOS, thyroid dysfunction, environmental factors, climate change, pollution, and endocrine disrupting chemicals. All of these things seem to drive diabetes, as I've shown you in the slide. And optimizing baby weight, really important. And I'm so glad Dr. Haritha talked about. And improving anemia, because anemia gives rise to small babies and other pregnancy complication, and follow-up of the mother after GDM, because we can prevent diabetes in that mother who's already a very high risk. And prevention of GDM, can we do that? That seems to be the holy grail. So next segment is the GDM segment. And this slide captures 10 times the increased risk of type 2 diabetes after GDM. The risk persists throughout life. If you see over there, and especially if the BMI is high, very high risk, even if the woman is in her 60s, 70s, and later, high risk. And then the study that Dr. Mohan already showed us, where as much as 20% of women develop dysglycemia or higher develop dysglycemia by the end of the year. Very high risk in women with GDM. And now if you look at risk factors for GDM, the list is even bigger, but many of them are modifiable. You can't modify age, you can't modify ethnicity, you can't modify family history. Everything else you can modify. So modifiable risk factors we need to address to prevent gestational diabetes. So the next one is again a study from India, I think from Salem, which showed us what happens when a mother is obese. See this slide. The GDM risk is so much higher, and unless we address obesity in women before they get pregnant, we can't do it after they get pregnant. The least we can do is kind of ensure that they don't gain too much weight. That's all we can do. We really can't do anything about the obesity itself. So when you look at GDM prevention studies, they've typically looked mostly at high-risk women. And typically they've looked at very obese people or previous GDM and instituted lifestyle modification or some metformin maybe. Even diabetes prevention programs said lifestyle is the best for all for prevention of diabetes. But for women with a previous history of GDM, maybe metformin is as good as lifestyle modification. So those are the things as far as that GDM prevention studies. When you look at consequences of GDM, I already mentioned that the children themselves develop pre-diabetes and diabetes, a very high risk for the offspring of women with GDM. Therefore, when you address GDM, you get two for the price of one. You get the mother and you get the baby, and maybe more babies. So you get not only transgenerational, but a multi-generational impact. So when you look at GDM, early and universal detection, I think that's very key, that we must diagnose. Prevention of excess gestational weight gain. And third is optimum, a good study from Malaysia showed that gestational weight gain, independent risk factor for GDM. So in addition to mother being obese, so we need to prevent gestational weight gain, prevent an optimum control of blood sugars during pregnancy, optimum surveillance for placental syndromes, hypertension, and all of that, and of course fetal surveillance for both growth restriction and macrosomia, and very important postpartum follow-up. A couple of things I want to talk about obesity very quickly. We all know that women, every time they gain too much weight during pregnancy or gain weight, and if that gestational weight gain is retained, then this is what happens. So one of the things that we need to stress upon really is that women try to achieve a decent weight before they plan the pregnancy, and then of course the whole postpartum weight gain has to be curbed. Because when they looked, this study, when they looked at, they stratified the maternal pre-pregnancy BMI and looked at women with both GDM and pre-pregnancy obesity, they found only when both were present that there was a problem. And so really important for us to address women of childbearing age with obesity before their pregnancy. Okay? And this slide is again a lovely composite of many things I've been talking about for the last few minutes. So current challenges and research gaps is the name of the slide, but it actually helps us to look at prevention. First is preconception counseling, optimization of risk factors. That's why I showed the risk factors, maternal nutrition, reduce maternal obesity, and identify pre-existing diabetes or MODY, early detection of GDM, and novel biomarkers for future GDM. That's all in the pipeline. Then if you look here, treatment of GDM, possibly subphenotyping of GDM, optimum gestational weight gain, epigenetic effects in the offspring, and then how to reduce the intergenerational things. And definitely encourage breastfeeding, decreases the risk of diabetes in the mom significantly. 6 months of exclusive and 1 to 1.5 years of complementary breastfeeding after that decreases type 2 diabetes by as much as 70%. And postpartum diabetes screening and lifelong diabetes prevention. We can't take our eye off the ball at any time. Very, very important. And, sorry. So this is I've come to the final part of my talk. This is a slide I got from my friend Amanda in Australia. She says we got to stop admiring pathology and start doing something. I absolutely love this thing because we know all the things we have heard so far. We already know everything. What are we going to do about it? That's the important thing. So key is to not let women get into the high-risk space at all. So again, as this slide shows, we sat scratching our head for a long time how to, what can we do to actually get into the the conscience of young women and work on preconception care. And so we came up with this project called as 3B, which is an umbrella program that looks at many things. One is called Yuvadi, which is a young women's awareness of diabetes and health initiative for high school girls, college girls, and young working women, primarily to talk about all these, what is health and what is nutrition, what is diabetes, what is gestational diabetes, what's preconception care. That's being rolled out as we speak soon. And then Be Ready is something I'm very proud of. It's an app that is going to come out very soon, maybe in the next month or so. This is for all women of reproductive age. It's a web-based app and a QR code with which they can take a survey and they will get a health report card about their preconception readiness. And then capacity building program for frontline health workers, and then for a bridal coalition, and of course learning all about GDM. Very quickly I want to show you, Yuvadi is something that is the sisterhood of health that we are very proud of. But this Be Ready, I probably will be coming to all of you for help, because each and every one of you in your own little circle, your school, your college, your workplace, your nurses, if you can keep spreading the message and making them take that survey, it's going to help us a whole lot. It's free, it's easy to use, and it is something that we are very, very proud of. And lastly, we are also have a big campaign that is coming out that talks about the A to Z of everything preconception care, so people know what they need to do. We need to focus on her because she is the future. She carries the future and she delivers the future. Thank you so much.